Epigastric hernia. These hernias arise through the midline raphe, linea alba, anywhere between the xiphoid process and the umbilicus, usually midway. When close to the umbilicus, they are called supraumbilical hernias. Epigastric hernias begin with a transverse split in the midline raphe, so in contrast to umbilical hernias, the defect is elliptical. It has been hypothesized that the defect occurs at the site where small blood vessels pierce the linea alba, or more likely, that it arises at weakness due to abnormal decussation of aponeurotic fibers related to heavy physical activity. Epigastric hernia defects are usually less than 1 cm in maximum diameter and commonly contain only extraperitoneal fat, which gradually enlarges, spreading in the subcutaneous plane to resemble the shape of a mushroom. When very large, they may contain a peritoneal sac but rarely any bowel. More than one hernia may be present. The most common cause of recurrence is failure to identify a second defect at the time of the original repair. Clinical features: the patients are often fit, healthy men aged between 25 and 40 years. These hernias can be very painful even when the swelling is the size of a pea due to the fatty contents becoming nipped sufficiently to produce partial strangulation. The pain may mimic that of a peptic ulcer, but symptoms should not be ascribed to the hernia until gastrointestinal pathology has been excluded. A soft midline swelling can often be felt more easily than seen. It may be locally tender. It is unlikely to be reducible because of the narrow neck. It may resemble a lipoma. A cough impulse may or may not be felt. Treatment: very small epigastric hernias have been known to disappear spontaneously, probably due to infarction of the fat. Small to moderate sized hernias without a peritoneal sac are not inherently dangerous, and surgery should be offered only if the hernia is sufficiently symptomatic. Over here in diagram 60.25, we can see the epigastric hernia from the external view. It's marked and it's supraumbilical. Surgery: this may be done by open or laparoscopic surgery. At open surgery, a vertical or transverse incision is made over the swelling and down to the linea alba. Protruding extraperitoneal fat can simply be pushed back through the defect or excised. Often a small vessel is present in the hernia content that can cause troublesome bleeding. The defect in the linea alba is closed with non-absorbable sutures in adults and absorbable sutures in children. In larger hernias and when a peritoneal sac is present, the surgical approach is similar to an umbilical mesh repair. Laparoscopic repair is very similar to that of the umbilical hernia, except that the defect is hidden behind the falciform ligament, which must be taken down before the undersurface of the abdominal wall. The margins of the defect must be clearly exposed and fatty contents reduced before the mesh is placed. Simply placing a mesh under the midline may not in fact remove the hernia when its contents are extraperitoneal fat. Coming to incisional hernia. Incisional hernia, the defect which arise after surgery. These arise through a defect in the musculofacial layers of the abdominal wall in the region of a post-operative scar. Thus, they may appear anywhere in the abdominal surface. Incidence and etiology: incisional hernias have been reported in 10 to 50% of laparotomy incisions and 1 to 5% of laparoscopic port site incisions. Factors predisposing to their development are patient factors: obesity, general poor healing due to malnutrition, immunosuppression or steroid therapy, chronic cough, cancer. Wound factors: poor quality tissue, wound infection, and surgical factors: inappropriate suture material, incorrect suture placement. An incisional hernia usually starts as disruption of the musculofacial layers of a wound in the early postoperative period. Often the event passes unnoticed if the overlying wound has healed securely. Many incisional hernias may be preventable with the use of good surgical technique. The classic sign of wound disruption is a serosanguinous discharge. Clinical features of these incisional hernias: these hernias commonly appear as a localized swelling involving a small portion of the scar, but may present as a diffuse bulging of the whole length of the incision. There may be several discrete hernias along the length of the incision, and unsuspected defects are often found at surgery. Incisional hernias tend to increase steadily in size with time. The skin overlying large hernias may become thin and atrophic so that peristalsis may be seen in the underlying intestine. Vascular damage to skin may lead to dermatitis. Attacks of partial intestinal obstruction are common because there are usually coexisting internal adhesions. Strangulation is less frequent and most likely to occur when the fibrous defect is small and the sac is large. Most incisional hernias are broad-necked and carry a low risk of strangulation. Over here we can see a large multilocular incisional hernia in figure 60.26. Below that 60.27, multiple defects seen during laparoscopic operation. You can see the adhesions. Incisional hernia, summary was 60.15. Incidence 10 to 50% after surgery, causation due to patient, wound, and surgeon factors, wide variation in size, often multiple defects within the same scar. Obstruction is common, but strangulation is rare, and open and laparoscopic repairs are possible. Treatment: asymptomatic incisional hernias may not require treatment at all. The wearing of an abdominal binder or belt may prevent the hernia from increasing in size. Principles of surgery: for most incisional hernias, surgery is relatively straightforward and both open and laparoscopic options are available. A number of principles apply irrespective of the technique used. The repair should cover the whole length of the previous incision. Approximation of the musculofacial layers should be done with minimal tension, and prosthetic mesh should be reduced to reduce the risk of recurrence. Mesh may be contraindicated in a contaminated field, example, bowel injury during the dissection, but in a clean contaminated field, such as after an elective bowel resection, mesh may be used if placed in a different anatomical plane to the contamination, such as in the extraperitoneal or retromuscular space. Appropriate systemic antibiotics should be used. Open repair: simple suture techniques without the use of prosthetic mesh for reinforcement, even with layered suture closure such as in Mayo, Keel, or Da Silva repairs are not recommended today because of the high risk of recurrence. However, they may not be only option in the presence of gross contamination such as peritonitis. The previous incision is opened along its full length to reveal a clinically unsuspected defect. The hernial sac, its neck, and the margins of the defect are fully exposed. The sac can be opened, contents reduced, local adhesions divided, and any redundant sac excised to allow safe reclosure of the peritoneum. Mesh can be placed in one of the several planes as for umbilical hernia repair. The simplest approach is an onlay mesh, but increasingly the retromuscular sublay repair is preferred by expert surgeons and is described below. Now we'll see the retromuscular sublay mesh repair. Vertical incisions are made through the fascia surrounding the rectus abdominis muscle so that the muscle can be separated and elevated from the posterior rectus sheath below. If possible, the medial edges of the posterior rectus sheath edges are sutured together with a continuous suture. In very large defects, this may not be possible, and below the arcuate line where the anterior sheath is deficient, being peritoneum and transversalis fascia only. In the case of transverse incision, where the defect extends lateral to the rectus sheath, internal oblique and transversus abdominis muscle form the posterior layer. A sheath of lightweight, large pore prosthetic elastic mesh is then laid between this posterior rectus sheath and belly or bellies of the rectus muscle. It is fixed to the sheath by interrupted sutures. The mesh must be large enough to ensure a 5 cm overlap of the underlying facial defect in all directions. Careful hemostasis and meticulous asepsis are essential during this operation. The anterior rectus sheaths are then sutured together over the mesh so that ideally the mesh is completely covered by muscle and fascia and is not lying in the subcutaneous plane. Redundant skin may need to be excised. The risk of post-operative serous fluid collections is reduced by suction drainage. Laparoscopic repair. Incisional hernias are increasingly being repaired by laparoscopic mesh techniques. Laparoscopy and division of the adhesions is initially performed. Hernia contents are reduced and the fibrous margins of the hernia defects are exposed. Often the falciform ligament and median umbilical fold need to be taken down. Some surgeons prefer to suture close the muscle defects first and then reinforce with mesh. Others simply fix the mesh under the defect with adequate overlap. The use of a tissue separating mesh is essential. Various techniques have been described to size and then position the mesh accurately. The mesh is fixed to the abdominal wall by staples or transfacial sutures which pass through all muscle layers to hold the mesh. In the presence of dense peritoneal adhesions, the laparoscopic surgeon needs to take great care because injury to the bowel is possible and may not be recognized. Diathermy is not used. If occult bowel injury does occur, it can lead to post-operative peritonitis, which is extremely dangerous complication. Management of a very large incisional hernia. Very large incisional hernias often require careful thought before treatment begins. If the volume of the sac is more than 25% of the volume of the abdominal cavity, and this can be calculated from the CT images, then there are likely to be issues of loss of abdominal domain when the hernia is repaired. The contents of the hernia, which have been outside the abdominal cavity for a long time, will not fit back inside, or if they do, it will result in high tension. High intra-abdominal pressure can lead to visceral compression and pulmonary complications due to impaired diaphragmatic movement. A tight abdomen can lead to wound breakdown and failure of the repair. Techniques to overcome the potential loss of abdominal domain include preoperative abdominal expansion with progressive preoperative pneumoperitoneum over several weeks, resection of the omentum and or colon at the time of repair, the use of prosthetic mesh to span the unclosable gap in the musculofacial layer, or the use of musculofacial advancement or transpositional flaps to achieve closure. Even if loss of domain is not a concern, large defects can still be very difficult to close, and the same special techniques may need to be used to avoid producing excessive tension in the repair. Ramirez's component separation technique, which incorporates relaxing incisions in the external oblique aponeurosis and or the posterior sheath, is very useful because this enables either the anterior or the posterior component of the rectus sheath to be drawn together. It may then be reinforced with a mesh. Patients with poor quality or redundant skin may benefit from a wedge excision of skin or fat lipectomy to improve the abdominal contour postoperatively. Repair of these very large hernias is highly specialized surgeon and is best done in specialist centers. Reducing the risk of incisional hernia. The incidence of incisional hernia may be reduced by improving the patient's general condition preoperatively where possible. Example, weight loss for obesity or improving nutritional state for malnutrition. Closing the facial layers with non-absorbable or very slowly absorbable sutures of adequate gauge is important. Traditional teaching was the sutures should be 1 cm deep and 1 cm apart. Recent work has shown that incisional hernia rates and reduced infection rates are gained when smaller and closer bites are used with 2-0 suture rather than traditional heavier materials. There is no evidence that interrupted sutures are better or worse than continuous. However, if continuous suturing is used, the tissue bites must not be too near the facial edge or pulled too tightly because they may cut out. It has also been confirmed that the optimal ratio of suture length to wound length is 4:1, Jenkins rule. If less length than this is used, the suture bites are too far apart or too tight, and the converse applies if more length than this is used. Drains should be brought out through separate incisions and not through the wound itself because this leads to hernia formation. Recent reports have suggested that placement of a prophylactic mesh in patients with high risk of hernia formation will substantially reduce that risk. This has been reported in obese patients undergoing bariatric surgery and also to prevent parastomal herniation, which occurs in up to 50% of patients. Now we've finished incisional hernia. Coming to Spigelian hernia. These hernias are uncommon although are probably underdiagnosed. They affect men and women equally and can occur at any age but are most common in elderly people. They arise through a defect in the Spigelian fascia, which is the aponeurosis of transversus abdominis. Often these hernias advance through the internal oblique as well and spread out deep to the external oblique aponeurosis. The Spigelian fascia extends between the transversus muscle and the lateral border of the rectus sheath from the costal margin to the groin, where it blends into the conjoint tendon. Most Spigelian hernias appear below the level of the umbilicus near the edge of the rectus sheath, but they have been found anywhere along the Spigelian line. You can see 60.28 Spigelian hernia. From the midline, it's moving to the groin. Okay, moving forward. There is a common misconception that they protrude below the arcuate line as a result of deficiency of the posterior rectus sheath at that level, but in fact the defect is almost always above the arcuate line. In young patients, they usually contain extraperitoneal fat but in older patients there is often a peritoneal sac and they can become very large indeed. They have also been described in infants and may be congenital, reflecting incomplete differentiation of the mesenchymal layers within the abdominal wall. Clinical features of Spigelian hernia. Young patients usually present with intermittent pain due to pinching of the fat, similar to an epigastric hernia. A lump may or may not be palpable because the fatty hernia is small and the overlying external oblique is intact. Older patients generally present with a reducible swelling at the edge of the rectus sheath and may have symptoms of intermittent obstruction. The diagnosis should be suspected because of the location of the symptoms and is confirmed by CT. Ultrasonography has the advantage that it can be performed in the upright patient because no defect may be visible with the patient lying down. Treatment. Surgery is recommended because the narrow and fibrous neck predisposes to strangulation. Surgery can be open or laparoscopic. At open surgery, a skin crease is made over the hernia, but no abnormality will be seen until the external oblique is opened. The sac and contents are dealt with and the small defect in the Spigelian fascia is repaired by suture or mesh laid deep to the external oblique aponeurosis. The plane of the mesh can be extended medially into the posterior rectus sheath if required. The external oblique epineuritis is closed over the mesh. Laparoscopy is useful if no sac is palpable, but in young patients with a hernia containing only extraperitoneal fat, no hernia will be seen from within the peritoneum. In such cases, the peritoneum can be incised and the extraperitoneal plane explode for the small defect, which can then be closed by either suture or mesh. When an intraperitoneal sac is present, laparoscopic repair can be performed using either the intraperitoneal onlay of mesh, IPOM, or TAPP technique. So summaries for Spigelian hernia, it's rare, often misdiagnosed, and high risk of complications are present. Coming to lumbar hernia, most primary lumbar hernias occur through the inferior lumbar triangle of Petit, bounded by the crest of ilium, lateral by the external oblique muscle, and medially by the latissimus dorsi. Less commonly, the sac comes through the superior lumbar triangle, which is bounded by the 12th rib above, medially by the sacrospinalis, and laterally by the posterior border of the internal oblique muscle. Primary lumbar hernias are rare but may be mimicked by incisional hernias arising through the flank incisions of renal operations or through incisionals for bone grafts harvested from the iliac crest. You can see the figure 60.29, inferior lumbar hernia towards the right side of the patient in the flank region, which contained cecum, appendix, and small bowel. Note the filarial skin rash on the buttocks. So differential diagnosis for a lumbar hernia must be lumbar hernia must be distinguished from a lipoma, a cold tuberculous abscess pointing to this position, a pseudohernia due to local muscular paralysis. Lumbar pseudohernia can result from any interference with the nerve supply to the affected muscles, the most common cause being injury to the subcostal nerve during a kidney operation. Treatment. The natural history is for these hernias to increase in size and surgery is recommended. Lumbar hernias can be approached by open or laparoscopic surgery. The defects can be difficult to close with sutures and mesh is recommended. The TAPP laparoscopic approach is gaining popularity. With the patient in the semilateral position, ports are inserted well away from the defect. The peritoneum is incised above the hernia and dissected back to expose the muscle defect. The content of an extraperitoneal fat is reduced and a mesh fixed with ample overlap. The peritoneum can then be resutured or tacked back to cover the mesh. Lumbar incisional hernias can be approached in the same way but large ones, especially if there is a component of the neuropathic muscle. Atrophy causing a diffuse bulge, pseudohernia, can be very difficult and muscle flap double breasting with mesh reinforcement may be required. Parastomal hernia. When surgeons create a stoma such as a colostomy or ileostomy, they are effectively creating a hernia by bringing bowel out through the abdominal wall. The muscle defect created tends to increase in size over time and can ultimately lead to massive herniation around the stoma. The rate of parastomal hernias is over 50%. For patients, it is very difficult to manage a stoma that is lying adjacent to or atop a large hernia. Stoma appliance bags fit poorly, leading to leakage. The ideal surgical solution for the patient is to rejoin the bowel and remove the stoma altogether, but this is not always possible. The stoma may be resited, but further recurrence is likely. Various open suture and mesh techniques have been described to repair parastomal hernias, but failure rates are high. Meshes are being placed in the retromuscular space. Laparoscopic repair is also possible using a large mesh with a central hole. It can be positioned around the bowel onto the parietal peritoneum. Recent reports have described the use of prophylactic mesh insertion at the time of formation of the stoma. A lightweight polypropylene mesh is inserted in the retromuscular space so that the bowel passes through a hole in the mesh center. Using this technique, parastomal hernia rates have been reduced significantly. Traumatic hernia. These hernias arise through non-anatomical defects caused by injury. They can be classified into three types. Hernias through abdominal stab wound sites. These are effectively incisional hernias. 2. Hernias protruding through splits or tears in the abdominal muscle after blunt trauma. 3. Abdominal bulging secondary to muscle atrophy that occurs as a result of nerve injury or other traumatic degeneration, akin to the lumbar pseudohernia seen after open nephrectomy. These can arise after a chest injury with damage to the intercostal nerves. Clinical features for traumatic hernias. Traumatic hernias present as any other hernia. The key to the etiology is in the history and the non-anatomical location of the hernia. Treatment. Surgery may be justified if the hernia is sufficiently symptomatic or if investigations suggest a narrow neck and hence a risk of obstruction or strangulation. Stab wound traumatic hernias are straightforward to repair using open or laparoscopic techniques as for other ventral hernias. Diffuse abdominal bulges are more difficult to correct and require some form of plication of the stretched musculofacial layer with mesh reinforcement to prevent further bulging in the future. Some bulging may persist, however. Rare external hernias, perineal hernias. This type of hernia is very rare and includes postoperative hernia through a perineal scar, which may occur after excision of the rectum. Median sliding perineal hernia, which is a complete prolapse of the rectum. Anterolateral perineal hernia, which occurs in women and presents as a swelling of the labium majus. Posterolateral perineal hernia, which passes through the levator ani to enter the ischial fossa. Treatment: a combined abdominal perineal operation is generally the most satisfactory for the last two types of hernia. The hernia is exposed by an incision directly over it. The sac is opened and its contents are reduced. The sac is cleared from the surrounding structures and the wound closed. With the patient in semi-Trendelenburg position, either laparoscopically or at open surgery, the abdomen is opened and the mouth of the sac exposed. The sac is inverted, ligated and excised, and the pelvic floor repaired by muscles apposition and, if indicated, buttressing of the repair with prosthetic mesh. Obturator hernia. Obturator hernia, which passes through the obturator canal, occurs 6 times more frequently in women than in men. Most patients are aged more than 60 years. The swelling is liable to be overlooked because it is covered by pectineus. It seldom causes a definite swelling in Scarpa's triangle, but if the limb is flexed, abducted and rotated outwards, the hernia sometimes becomes apparent. The leg is usually kept in a semi-flexed position and the movement increases the pain. In more than 50% of cases of strangulated obturator hernia, pain is referred along the obturator nerve by its geniculate branch to the knee. On vaginal or rectal examination, the hernia can sometimes be felt as a tender swelling in the region of the obturator foramen. These hernias have often undergone strangulation, frequently of the Richter type, by the time of presentation. Treatment: surgery is indicated. The diagnosis is rarely made preoperatively, and so it is often approached through a laparotomy incision. The full Trendelenburg position is adopted. The constricting agent is the obturator fascia, which can be stretched by inserting the operator's index finger or suitable forceps through the gap in the fascia. Content is reduced. If incision of the fascia is required, it is made parallel to the obturator vessel and nerves. The contents of the sac are dealt with in a standard manner. The defect cannot simply be closed because one margin is bone and the obturator nerve and vessels run through it. It is best closed using a mesh plug. In the absence of mesh or in an infected field, the broad ligament can be used as a plug. Laparoscopic TAPP repair may also be performed again using a mesh. To avoid nerve injury, glue can be used to fix mesh over the defect. Gluteal and sciatic hernias. Both of these hernias are very rare. A gluteal hernia passes through the greater sciatic foramen, either above or below piriformis. The sciatic hernia passes through the lesser sciatic foramen. Differential diagnosis must be made between these conditions and a lipoma or soft tissue tumor beneath gluteus maximus, a tuberculous abscess, a gluteal aneurysm. All doubtful swellings in this situation can be characterized with CT scanning, but if in doubt, they should be explored by operation. Umbilical conditions in adult. Chronic infection. Chronic infection occurs in umbilical area, particularly in patients with poor hygiene. It may occur in obese people and when a paraumbilical hernia is present. It can be due to a plug of keratin causing chronic irritation. It is often encountered during the elective surgery and may complicate the insertion of a laparoscopic port at the umbilicus. A range of bacteria and fungi can be involved. Occasionally, a rapid onset superficial cellulitis occurs even after minor surgeries in this region. It is normally a streptococcus and can be treated with penicillin or other appropriate antibiotics. Pre-existing infections should be treated before surgery where possible. Chronic fistula. Patients may present with a persistent discharge from an umbilical area. This may be due to simple superficial infection or possibly an infected epidermoid cyst within the umbilicus. However, it may also be due to a fistulous connection to deeper structures. In normal patients, the umbilicus is connected to the liver, bladder, and gynecological organs by various ligaments. Diseases of these organs, such as infection or malignancy, can extend along these ligaments to reappear in the umbilicus as a mass or fistulous discharge. Chronic fistula may be a complication of umbilical hernia repair due to chronic infection of a mesh or around non-absorbable suture material. In most cases, this problem arises soon after surgery, but occasionally in chronic infections can occur months or even years after an operation. Antibiotics may help, but most commonly the synthetic suture or mesh will need to be removed with a risk of recurrence of the hernia. In fetal life, the umbilicus was also connected to the gut by the vitellointestinal duct. In most patients, this duct becomes totally obliterated and vanishes. The bowel end of the duct may persist as Michel's diverticulum. More rarely, the umbilical end persists, leading to chronic discharge. If an abnormal connection between the bowel and the umbilicus persists, then this band can act as a cause of additional intestinal obstruction. Patent urachus. Connection between the urinary bladder and umbilicus usually persists in later life. This is due to increased pressure in the bladder as a result of obstruction from conditions such as prostatic hypertrophy. The cause of obstruction should be dealt with initially, but if the problem persists, then surgical excision of the patent urachus might be considered. Malignancy at the umbilicus. Primary squamous carcinoma may occur. If tumor presents at the umbilicus, it is most probably due to spread from the internal organs along internal ligaments, example, from the liver along the falciform ligament. A malignant mass at the umbilicus is called a Sister Joseph nodule. It usually indicates very advanced malignant disease, and surgery probably has little to offer. General infection of the abdominal wall. The skin of the abdominal wall, similar to all skin, is prone to develop superficial infection that may be spontaneous due to minor trauma or infection of skin lesions such as an epidermoid cyst. Although antibiotics will suffice in most patients, if an abscess develops, then surgical drainage may be required. The close proximity of the bowel and bowel organisms opens the abdominal wall to attack from a wide range of highly virulent bacteria. Most commonly, these are released during abdominal surgery such as appendectomy, and hence the need for appropriate antibiotic prophylactic cover. Figure 60.30, secondary nodule at the umbilicus, Sister Joseph nodule seen. It's malignant nodule. Synergistic gangrene. This rare condition is due to the synergistic action of non-hemolytic streptococci and staphylococci causing rapid tissue necrosis and overwhelming systemic infection. It requires immediate administration of high-dose broad-spectrum powerful antibiotics in combination with early debridement of any non-viable tissue. Hyperbaric oxygen therapy has been advocated. Other forms of severe abdominal wall infections occur, generally known as necrotizing fasciitis, example Fournier's gangrene. All of these conditions have high associated morbidity and mortality. They occur in debilitated and immunocompromised patients, but can occasionally occur in healthy patients. Rapid diagnosis and aggressive surgical debridement treatment are the key to success. Cutaneous fistula. Due to the thickness of the abdominal wall, it is rare for abdominal inflammatory conditions to discharge spontaneously through the wall to the skin. Chronic intraperitoneal abscess arising after occult bowel perforation, appendicitis, diverticulitis, and cholecystitis are the most likely sources. CT will locate the internal abscess and suggest the likely origin. Treatment today is usually by CT or ultrasound guided drainage, but the surgeon may be called on to remove the source organ, example gallbladder. Malignancy in its later stages can occasionally erode through the abdominal wall. Crohn's disease also has a tendency to fistulate through adjacent organs and may develop an enterocutaneous fistula. Abdominal compartment syndrome. Surgeons are increasingly aware of the harmful effect of high intra-abdominal pressures that can occur in severe intra-abdominal sepsis such as pancreatitis and also aortic aneurysm rupture. High pressures leads to reduced blood flow and tissue ischemia, which contributes to multi-organ failure. Although the abdominal wall has elasticity, if intra-abdominal volume increases due to fluid, gas, pus, tissue edema, etc., then maximal capacity can be reached and pressure rises to a critical level. Tension releasing incisions equivalent to a fasciotomy have been suggested, although this is not widely practiced. In some cases, after surgery for severe intraperitoneal sepsis, the surgeon cannot close the abdomen and may leave the incision wide open, covering the abdominal contents with mesh or a saline-soaked dressing, planning to return at a future date to close the defect. This is called laparostomy. We can see over here in figure 60.31, bacterial synergistic gangrenes of the chest and the abdominal wall. The area has become gangrenous and looks like a soothed leather. Beware of amoebiasis cutis. This is one of the complications. Neoplasm of the abdominal wall. As the abdominal wall is composed of muscle, fascia and bone, benign and malignant tumors can arise from each, although these are rare. Desmoid tumor. This is usually considered by pathologists to be a hamartoma and is more common in women. Some, however, believe it to be a fibroma and possibly the result of repeated trauma. Desmoids have been reported in familial adenomatous polyposis. Histologically, they contain plasmodial cell masses resembling giant cells. They undergo central myxomatous change. Surgical excision with a wide margin is required to prevent recurrence, which is a frequent problem. Fibrosarcoma. These tumors can occur anywhere in the body. They are generally highly malignant and respond poorly to both radio and chemotherapy. Wide excision will often require plastic surgical reconstruction. Thank you.